Today I'm going to tell you about ureteropelvic junction obstruction or PUJ obstruction. When we see the ureter anatomy, the ureters are bilateral tubular structures which are responsible for transporting urine from the renal pelvis to the bladder. They are generally 22 to 30 cm length with wall composed of multiple layers. There are sites of ureteral narrowing. Those sites are ureteropelvic junction as the ureter crosses the iliac vessel, and uretrovesical junction. Ureteropelvic junction obstruction is defined as a partial or complete obstruction of the flow of urine from the renal pelvis to the proximal ureter. It can be congenital or acquired, with a congenital PUJ obstruction being one of the commonest causes of antenatal diagnosed hydronephrosis. When we see the epidemiology of PUJ obstruction is the most common site of urinary tract obstruction in children. Majority are discovered antenatally. PUJ obstruction is the most common anatomical cause of antenatal hydronephrosis, which is more common in boys than girls. And most of PUJ obstructions are on the left side. 10 to 40% are bilateral. Regarding pathophysiology, PUJ obstruction is caused by anatomic lesions or functional disturbance that restricts urinary flow, resulting in hydronephrosis. Most cases are thought to be due to partial obstruction, because complete obstruction results in rapid destruction of the kidney. In some cases, partial obstruction may also lead to progressive deterioration of renal function. When we see the etiology is both congenital and acquired. When we see the congenital, intrinsic narrowing is one of it. In most cases of UPJ obstruction, the upper segment of ureter is narrowed or kinked, resulting in obstruction of urinary flow. Although the underlying mechanism is not proven, it is thought that there is an embryologic disruption of proximal ureter that alters circulatory muscular development and collagen fibers and composition between and around muscular cells. From the congenital cause of PUJ obstruction, the other is extrinsic narrowing. In about 10% of pediatric PUJ obstruction, an aberrant or accessory renal artery or arterial branch may cause the lower pole of the kidney, resulting in compression of PUJ and the blockage of urinary flow. In addition to congenital, there are also acquired causes such as vesicoureteral reflex, benign lesions such as fibroepithelial polyps, stone disease, post-inflammatory or post-operative scarring or ischemia. Most congenital PUJ obstructions are diagnosed antenatally during antenatal ultrasound. So most of the neonates are followed from antenatal ultrasound, whereas older children can have urinary tract infection, flank mass, occasional flank pain secondary to primary UPJ obstruction, hematuria if it is associated with infection. In adults, back and flank pain correlates with periods of increased fluid intake ingestion of food with diuretic properties. And also UTI, pyelonephritis, hypertension, and abdominal mass can be the presentation. Regarding the diagnosis, PUJ obstruction is generally suspected when imaging studies, usually ultrasonography, demonstrates hydronephrosis. The diagnosis is confirmed by diuretic renography. On ultrasonography, it shows a dilated renal pelvis with collapsed proximal ureter. With Doppler sonography, the obstructed kidney can show higher resistive indices. Diuretic renography is performed to differentiate between obstructive versus non-obstructive hydronephrosis. In PUJ obstruction, this diuretic renography demonstrates excretion after administration of diuretic from the collecting system, whereas in mechanical obstructive, hydronephrosis will demonstrate no downward slope on renogram with retained tracer in collecting system. The other is CT scan. CT scan is alternative to ultrasonography in the symptomatic child. This may show evidence of hydronephrosis with collapsed ureters, and is useful for assessing crossing vessels at PUJ, especially when surgical intervention is planned. Otherwise, it is not preferred modality due to radiation exposure. The other is voiding cystoretrogram. This is performed in patients with hydronephrosis to confirm the presence or absence of vesicoretral reflex of both the affected and the contralateral kidney. 10% of patients with PUJ obstruction have contralateral low-grade vesicoretral reflex. Identification of vesicoretral reflex is important because children with concurrent vesicoretral reflex and PUJ obstruction may be at high risk for severe infection. In addition to diagnostic imaging, we can also do CBC, coagulation profile, electrolyte level, renal function test, and also urine culture if we suspect UTI. When we see the management is conservative. 50% of antenatal hydronephrosis resolved postpartum. Observation that asymptomatic hydronephrosis can resolve spontaneously. Studies with infants with renal function greater than 35 to 14 in the affected kidney and variable washout patterns. Rule of one-third stays the same, one-third improve, and one-third worsen. Indication for surgical intervention include presence of symptoms associated with obstruction, impairment of overall renal function, progressive impairment of ipsilateral function, development of stones or UTI, and hypertension. A pyeloplasty is a surgical procedure that is indicated for PUJ obstruction. It is an open surgery to cut out the area of scarring and reconnect the ureter to the kidney. This is all about PUJ obstruction. Thank you for watching.